and Adam and the team, yeah? Great. To talk about your work over the course of this week. So, Bev.
And we just wanted Jen, because it's the first time this value stream's reported out, just
Right.
to share some information
Excellent.
with the audience about what we're up to.
That's great, Jenny, yeah. Smash it.
Hello, my name's Jenny Earhart. So this is our value stream map, value stream 5. It's all about time to first consultant admission on the acute floor, which is one of the 7-day services standards that we've to meet. And our current state is that despite all the hard work of the staff on that floor, we don't meet that for the majority of our patients. So the future state describes an aspiration to exceed that and actually to have a first consultant review right up at the front end when patients first come through. My understanding is the exec sponsor is only contacted during an RPIW week if something has really gone wrong. So I'm dead chuffed that I don't know what to say. So over to you.
Thanks very much, Jenny. Hello, my name is Jimmy Parvin. I'm a Kaizen Promotion Office Specialist and I've been the privileged workshop lead for this RPIW, which is on the acute floor, as you've heard, and the process we've been looking at is the medical clerking process. So during our observations we identified lots of variation and waste in the process, and the team saw how this waste took them away from completing tasks that really add value from the perspective of a patient and really increase their burden of work. And you're going to hear from the team now about how they use the lean principles within the Leeds improvement method, such as 5S, mistake proofing, visual management, to deliver some significant improvements for their patients and to reduce their burden of work.
Hello, my name is Helen Gilbert. I'm the Kaizen Promotion Office lead, but it's lovely not being in charge this week. I've been under Jimmy's leadership this week, which has been great. It's really important that we measure the success of our work, and what you will see here is where we started in terms of our baseline data. We've been measuring, we always measure the lead time of a process. How long does it take to carry out the medical clerking process to safely admit a patient onto our wards? We also have been looking at quality and the defects in our work, and again an interesting common theme emerging from a lot of our rapid process improvement workshops, but the number of times patients aren't ready for this particular process, and also the number of times our hard-working staff are interrupted in the course of their day-to-day work. And we've been looking at the productivity for our advanced clinical practitioners and our doctors in training in terms of how much of their time they spend on this particular process. And always in terms of the discipline we want to bring to our work environment, our 5S goals are around the ops room, which is where all this work takes place across ward 27 and 29 on the acute floor. It's really important that we focus on the demand of our work. It's a core component part of the Leeds improvement method. And so we have a concept called Tack Time, which is what is the pace of the demand coming up onto these ward areas. On ward 27, they have on average 19 patients a day. That's a patient every 76 minutes appearing in that ward area. And on ward 29, a demand of 14 patients a day, which is a patient appearing every 103 minutes.
Hello, my name's Bev and I'm a matron in acute medicine, and I am a co-process owner for this improvement work. So I think it's fair to say that initially I had quite a few reservations about this work, which I did vocalise, and I think that's because it's new and it's about my lack of understanding about what was ahead of me. But in the build up to this week we had meetings with the KPO team, and they helped to increase my understanding of the process, and they also provided lots of data and pictures of our areas which actually make you stop and look at what you do every day. So in relation to the pictures, when I saw them, it just screamed chaos. And if it screams chaos at me, it screams chaos at patients and relatives when they arrive on the ward. And I think for me, you're there every day, but you don't see it because you're there every day. In relation to the data, the interruptions was a biggie for me. So realising that our medical clerking doctors are interrupted on average of once every 8 minutes during the clerking process, which then leads to the increase to make mistakes and to go over information repeatedly. This week we've produced some flow charts to identify waste and duplication, and the KP officers described to me something about human potential waste, which I'd never heard of. And that's related to the surveys that we'd done before this work and the reaction from the junior doctors within our teams. And they described feeling a perception of being disengaged and not able to affect what happened. And I find that really sad, because everyone should be able to impact on what happens. So we have to do something about that. And then the duplication was a big thing for me, that we ask questions, the same question 2, 3 and 4 times. And so if I were a patient sat there, I'd be thinking, do these guys not talk to each other? And I'd probably lose some trust in what they were doing. Personally, I've learnt lots. I've learnt what a mental valley is, and that I have several of them. Maybe not as many as I had on Monday, but that's a work in progress. I think the challenges that I found was keeping focus this week and keeping in the scope of what we were set to do and not trying to fix the whole thing in 1 week or 2 days. And then the realisation for the group, I think really, that if we make the small changes and we embed them and sustain them, then it'll give us a foundation to build and create a first-class service for our patients and for our staff. Victoria.
Thank you. My name's Victoria Watts. I'm a geriatrician on the acute floor. I've been a member of the team this week. So as we've heard from Bev, there's often at times an air of confusion and chaos on the acute floor. And we think to help remove this, we ought to organise the ward better at the start of the day. So our first step has been to produce this staffing board. Currently doctors arrive on the ward at 9 o'clock, and this is where the chaos starts, with doctors trying to decide where they should be and what they should be doing. To overcome this board is an easy visual description listing the roles and responsibilities of each member of the nursing team and the medical team. Nurses have been using this successfully for a long time, and now we're going to roll it out to be medical staff. So if we look at the picture, you can see how the ward is divided into 3 team areas, depicted by different colours. Each area now has a nursing member of staff assigned to that area, along with the medic, and we've also added onto the bottom the different teams coming onto the ward, such as EDATs and pharmacists. So this should enable doctors and nurses to communicate much better with each other, and thereby reducing the unnecessary interruptions that we've been hearing about. Using this approach has also enabled us to free up 1 member of the doctors team and now protects them into a clerking and assessment role. So we've removed all the interruptions from that member of the team, making the clerking process much smoother and much better for the patient and the member of staff. The other part of our work has been to produce a production board. Currently, information regarding flow across the CSU is gathered and held by matrons and flow managers, but it isn't communicated very well to the people on the shop floor, and it's the people on the shop floor who are best placed to make changes and help with patient flow. So this board is going to show the health of the staffing and also the health of the CSU, and it will be updated by patient flow at 4 times throughout the day. Starting at the top of the board, we're showing the activity in the previous 24 hours, and this will give us an idea of how busy we're likely to be in the next 24 hours. We're then moving on to the staffing, and we've developed a RAG rating for the staffing for both nursing and medical. And feeding into this rating, we've got both the numbers of the staff that are on the ward, but also the types of patients that are on the ward and the number of patients that we're expecting. Again, this will be updated throughout the day, and the staff on the ward will feed into this rating to reflect how they feel the ward is flowing at any point in time. At the bottom, we've included information about the CSU. We've included this to enable staff at a local level to begin to plan and respond to the bigger picture across the CSU in a much more timely manner.
Thanks, Victoria. My name's Jen. I'm one of the trainee advanced clinical practitioners working in acute medicine, and I've been a team member during this improvement week. Following on from what Victoria said about identifying who's responsible for what we also wanted to do was help direct people towards the tasks that they had to get done throughout the day, and that's so that you don't have a free-for-all and everyone wanting the same notes and also the same patients at the same time. Using a priority list that was already quite embedded on a ward to identify which patients were the priority for the consultant ward round in the morning, what we've done is communicated with our pharmacists and EDAT teams as well as our nursing teams that any patients that feature on this priority list for the morning should have a protected time until the consultant ward round has taken place, and that's including protecting those notes for that period of time. We communicate that those notes are now available to the wider team by ticking them off the list, and we automatically divert flow to different patients throughout the morning by doing this. One of the biggest issues was finding medical notes on a ward, as there's many places and many homes for them once somebody's picked them up. So using Kanban cards that are colour-coded, and the responsibility of the person removing the notes to put in the notes trolley, we can identify very quickly and without interrupting our colleagues to find out where those notes are. This method has already been adopted by some teams on some of the wards, and what we hope is by coordinating it and making it consistent, we can get some concordance from our colleagues in using the process. Following on from one of the things that's been identified by our observation team is about taking medication history from our patients. And whilst we've identified there's a lot of duplication in that process, we've identified that it's quite a complex issue in itself and is probably a whole other project that we haven't been able to completely address in this week. What we have seen is that taking medication history from patients is largely populated from a pre-existing list on a server that we have, PPM, and not a lot of time is spent with the patient to actually find out that information. What we want to do is streamline that process and reduce the chance for errors, and a simple form would be to print the list that's pre-existing on the PPM server. Unfortunately, there is a button for that, but at the moment that button to print is not activated, and that's one of the things we would like to ask for some help with, is making that a priority for PPM to resolve for us. Short term, we have come up with a fix this week, and that is to print screen that page and to attach it into the medical booklet, and therefore allowing our clinicians to actually spend time with the patient to confirm that list rather than simply copy that list over. Thank you.
Hello, my name's Adam Burns. I'm one of the acute medicine speciality registrars, and I've been a team member in this process. I'd like to talk to you about improvements that we plan to make in the collecting of collateral history. Now, collateral history is often taken from patients, their relatives or carers, and it involves information about how they've come to hospital, what their circumstances are at home, or any concerns that friends or family might have. And currently it's collected by multiple members of the multidisciplinary team, and it's clearly information that's key to that patient's journey through hospital. We wanted to make this a single unified process so that information flows smoothly without repeating the process by multiple staff members. And so what we've decided to do is we've actually come together and had an agreement that we have a single point of documenting collateral history within the medical documentation that's shown here on the screen. And we've also agreed that it's actually a shared responsibility now, so that actually it's okay for members of nursing, medical or allied health professionals all to contribute to that same piece of information, and that way it avoids multiple handovers or multiple collections of information. I'd also like to talk about our ops rooms. These are where members of the team meet, they kind of collect information about patients and often document in the notes after they've seen a patient. There's lots of information around in these rooms, as you can see on the boards. Before we started this process, it was really important that all of that information was useful to the tasks that we had in hand, and so we've used the 5S methodology to kind of sort and simplify the information that was there. One of the easiest steps we did was just to remove items that were out of date. We also designated boards for particular areas of clinical teams. So for example, pharmacy had their own board, so if you know you've got a pharmacy related query, that's where you would go to that board to look. We also, in terms of thinking further down the line, we were thinking about how we kind of sweep this information to keep it current, and also about who has responsibility for upkeep of that information. And so we hope we've empowered ward teams to know that's within their remit, and they have got the power to do that and keep that information up to date in the longer term. And last of all, we talked about at the start how patients aren't always immediately available when they go to be assessed by a clinician. And that might be just that they're not at the bedside, or it might be they're having care tasks like being taken to the toilet or food and drink preparation. And so what we decided was a really simple measure. We could just have a pre-visit by the clinician to let them know that I will be on my way to see you in the next 10 minutes or so. And because we've now got a dedicated assessing doctor, that's possible to do. And that means if there are any care tasks that need to be done, they can be done before you start, and that patient will be at the bedside.
Thank you. I'm Hannah, I'm an acute medicine consultant, and I've been a team member this week. So I'd like to talk a little bit about our future vision of how we assess patients, and we've looked over the week of making small adjustments that we can absolutely go into our wards and make in the next few days and weeks. But we wanted to also address what our future vision for this assessment of our patients is. We want to improve patient experience further, we want to streamline the process, and provide effective and fulfilling training for our trainees and for our ACPs to improve that engagement that Bev talked about that we've maybe lost a little bit along the way. So we really want to think about an integrated clinical assessment. So having the nursing staff, the consultant, the trainee or ACP, EDA and pharmacy all reviewing that patient as soon as they hit the ward, if we can, but very soon after, and making an integrated clinical assessment of that patient. We've come up with a standard work description of how we think that might look, and on the next 3 Wednesday afternoons we're going to just run with that and see if we can actually just do it and see how that goes. We've set up a PDSA cycle so we can review after doing it each Wednesday afternoon and then make adjustments as we go along. And we'll be reporting out in the 30-day report out just to see how that works and see if it is something that we really should be aiming for in the future.
So how did we fare over the week in terms of our target progress report? We simulated through Jen yesterday, who went through a medical clerking process on the acute floor, and actually despite the team thinking that Morag had set them quite a challenging target of 45 minutes, Jen actually went uninterrupted through the medical clerking process in 48 minutes and 20 seconds. And actually the additional time in there was because for the first time this particular example involved patients' relatives in the bed space with the patient. So actually there was much more time spent sharing information and getting information from the relatives, which wasn't replicated in the baseline data. So that is a particularly successful clerking process. In terms of our quality and defects, Jen went to inform the patient up front, as the team had wanted to happen, that this medical clerking process was going to take place, so that that patient was available when this process started. So that for that particular patient we were defect free. The number of times the clinician is interrupted during the medical clerking process, she did have a bit of a posse round her in the form of Adam Cole, the business manager, and myself, but she was uninterrupted in this process. So, and the staff around her were very respectful of that fact. What you actually see in terms of our productivity gain is this is the amount of time that the advanced nurse practitioner, advanced clinical practitioner and a doctor in training is spending. Actually, based on that simulated process, if they can sustain and improve on this, it puts the equivalent back in each of these ward areas of at least one whole time equivalent hours in terms of reducing those interruptions, which is quite an amazing achievement.
So, following this week, we capture all our actions on a newspaper, which you can see here, and excluding the trial that Hannah's talked about that she's going to start next week, a lot of the things we've made good progress on already, and we want to go out there and continue to make that progress and look forward to reporting back in 30 days.
So, key learning. So, sharing information is a respectful behaviour. So, by committing as a team to make necessary information visible, we eliminate waste, as you've heard, like interruptions, duplications, defects. Fundamentally, this helps us keep patients safe and reduces the burden of work for staff. We've heard some descriptions of disconnect, if you like, across teams. So we agreed it's vital that we connect as a multidisciplinary team across professional boundaries if we're going to deliver this safe, quality care for our patients. And the other theme we picked up on was that you might have heard some ideas that have been tried before, and other team members who are perhaps in the audience would identify with this. But as a team, I think we realised that the reason these ideas fail is perhaps because we don't challenge the behaviour behind the idea that we need in order for it to be successful. Thank yous. A huge thank you to Stuart for freeing up the undergraduate hub, and for the team up there who have been really fantastic hosts for our event this week. Can't speak highly enough. If you need a venue, go and knock on the door. Sorry, Stuart. The team is beyond the people in front of you. There's some in the audience, some who aren't here. So we've got to mention Jess Lovett, who's one of our doctors who joined us, Sam as one of the consultants, Charlie, another consultant, Chris, an expert from pharmacy who gave us his valuable time, and Adam Cole, who, as well as being a bouncer to stop Jen being interrupted, is the business manager and is a co-process owner for this piece of work. The team on 27 and 29, tolerance is the first word that comes to mind, but they're also enthusiastic, and I have no doubt that their support over the next 30 days will lead to some significant improvements on PDSA and moving this work forward. Morag, I've not had to phone her too much this week, but she sponsored this work, listened, supported the planning, and been behind the team, as well as setting them the challenge for the week, which was our platform. And finally, our guest from Virginia Mason over in Seattle, Chika Lambert, is one of our senseis who's been here for the week, as well as sharing her expertise with some of our Lean for Leaders colleagues with the KPO team, has also been very much in part of this workshop, helping me continuously improve and probably Helen a little bit as well. So thanks to her, and that concludes our report out.
Brilliant. Fantastic. Thank you ever so much. That's tremendous. And congratulations to all of you, and great effort through the week, and impressive to see the progress that you're making, and looking forward to seeing how we work on that. Can I invite those who have also reported out just to come back to the front? So Rob, Karen, team. Now he's having seen 3 really great report outs, it's your opportunity, folks, to kind of pick up any questions. We've just got a few minutes. Well done, Sam.
I couldn't let him hide in the audience.
Just to pick up any questions or comments from any of the 3 that you've heard this lunchtime. Go on.
So I'm Karen Levengood, Head of Nursing for Outpatients, and actually the project sponsor for this RPIW week. I think the thing for me, it was very much that when we started this, we have a significant problem with nurse staffing in this department, and we met with the only thing we need is more staff, more staff, more staff. The improvements have been made with no extra staff. We have those staff starting, so the first one started this week, the next one starts over the next few weeks. But I think what's really exciting is that those staff will come into new processes, and right from the beginning will work that new way.
Yeah.
I know when I met with Kath this morning, they're a little disappointed with their progress. And
Why on earth?
Absolutely.
Why on earth?
And I think it is that bit about, okay, you wanted to get way over here, but actually you've made some fantastic improvements with what you have done. So I think as a group, you should be really proud of yourself, but also the team in the department who I've seen firsthand them starting to question each other when they're not doing the things that they should be doing, because they now recognise it. So I can't tell you how proud I am of you.